To grow correctly, you need an adequate placenta in pregnancy. You need a critical mass. You need a good blood flow. You need a minimum of 600 milliliters per minute of maternal cardiac output. Reaches the placental exchange area of up to 12 squared millimeters at term. There's two waves of angiogenesis, i.e. how this placental mass invades the mom's body, and what does this do to mom's vessels, such as her uterine vessels? How does that create that angiogenesis? The placenta function is energy intensive and consumes 40% of oxygen supplied and 70% of glucose supplied. So the placenta needs as much oxygen and glucose as the baby. So it's really important. The optimal growth and development depends on maternal nutrient and oxygen delivery to the uterus that leaves sufficient supply for the fetus. Okay, question. Out of those kids that are less than the 10th percentile, how many are truly growth restricted and how many are just constitutionally small? 30% are probably truly sick and are IUGR, and 70% are just normal, constitutionally small. When you see a small baby, look at the difference between the abdominal circumference and the femur length and the head circumference. Remember, IUGR is, quote, head sparing. So you're going to see decreases in the abdomen and the femur, and the head circumference tends to be more normal. Also, look at mom. Is mom 4'11"? Is she just not destined to have an 8-pound baby? Or is mom 6'2"? And dad is 6'4". Look at mom and dad. I think that's a real important point. Test question. What is the percentage that we use in the United States to say a baby is growth restricted? Is it 10%, 5%, or 3%? 10. It's 10%. In Europe and in other places around the world, they're using 5 or 3%, which I think they're probably right. Because I think 10% is, there's many of those kids are just normally grown. SGA should only be used in reference to the infant and IUGR to the fetus. So the 10th percentile is the convention in the United States. Other definitions, 5 or 3%. Asymmetric IUGR, again, abdominal circumference delay, femur length delay. Why is the abdominal circumference small? They utilize peripheral fat. They utilize glycogen that's stored in the liver. And those are the main components of why the abdominal circumference starts to lag. The blood and the nutrient supply to the upper part of the body increases, predominantly resulting in this head-sparing effect. And what happens in the heart that causes that? It's that shunting straight across the ductus venosus opens up and shunts blood across that foraminal valley into the left side of the heart. Symmetric IUGR. Test question. Know the differential diagnosis for symmetric IUGR. The head and the body are similarly affected. What's the differential? Aneuploidy, syndromes, viral infections, or worsening asymmetric IUGR. The etiology for IUGR, many medical maternal conditions. Probably the most important one that we can make a difference on is cigarette smoking. Many fetal causes as well. Genetic disorders, infections, placental disease due to inadequate angiogenesis, which we see a lot in first-time moms. Structural anomalies are at higher risk. Teratogens, Coumadin. There are medications that are associated with IUGR. Placental mosaicism, which we don't talk about, is kind of a term that no one is terribly comfortable with, but that can be a cause of IUGR, and up to 25% of, especially of unexplained IUGRs. Twins are at risk. And then multiple risk factors can act synergistically. So when you look early on, you want to see this wave of trophoblastic invasion, i.e., this developing fetus kind of invades mom's circulation and has an effect on mom's uterine arteries to open them up, so to speak, to provide low resistance. And you see this nice diastolic flow. This is an abnormal uterine artery Doppler down below here. Diastolic notching, not a lot of diastolic flow. This is a child that may be at risk for problems down the road. Fetal manifestations, nutrient deficits become universal and result in decreased fetal and placental size. When oxygen delivery falls below a critical value, fetal oxygenation begins to fall and is eventually accompanied by fetal hypoglycemia. And the fetal organs do have the ability to auto-regulate. Other fetal manifestations, the hypoxemia is a trigger for erythropoietin release, an increase in whole blood viscosity, a decrease in membrane fluidity, and platelet aggravation may be important precursors for placental vascular occlusions. So this stuff all comes into play. Immune dysfunction at the cellular and humoral level may explain why these babies are at higher risk of infection after birth. When you look at what happens early on, the early phases, there's preferential streaming to essential organs. And so the venous flow across the liver shunts, this shunt here called the ductus venosus, shunts blood across the right side, across the foramen ovale to the left side, and is attempting to protect the brain, right? And the coronaries, first branch of the aorta. Coronaries, your carotids. Late circulatory response is more cardiac function related. So you'll see cardiomegaly, tricuspid insufficiency, abnormal venous Dopplers, and spontaneous heart rate decelerations. And I think venous Dopplers are really what come into play here, and we'll talk about that as we go through. Then there are kind of these CNS abnormalities where, again, it goes back to your biophysical profile. Behavioral milestones, tone, body movements, reactivity, and these obviously, as we said before, the first to show is the last to go, or vice versa. So in other words, you're going to lose your reactivity first, then your breathing and whatnot, and that gets into babies are getting sick. They're also not perfusing their kidneys well, so their amniotic fluid volume is decreasing, and that's noted in your AFI or your largest vertical pocket. But always think of that as a good marker of chronic hypoxia as well. Intrapartum, the prognosis, their intrapartum complications are increased. Up to 50% will exhibit abnormal heart rate patterns, and they do have an increased risk of cesarean delivery. Oligohydramnios, common finding, makes the umbilical cord vulnerable to compression. And then, of course, there's a sudden case of fetal death that not all of our NSTs can predict. And our low APGAR scores and cord blood acidemia are also increased. What are the neonatal complications? Polycythemia, hyperbilirubinemia, hypoglycemia, hypothermia, apnea, need for intubation in the delivery room, seizures, sepsis, neonatal death. To me, it's uncertain whether IUGR truly does accelerate pulmonary maturity, and I think studies are conflicting. I know a lot of people say, well, the baby's stressed out, so it secretes its own inherent corticosteroids. I think the studies are very conflicting on that point. So I don't view it as any different. I think, if they're at risk and they're under 34 weeks, they get steroids, betamethasone to accelerate lung maturity, to reduce bleeding in their head, to reduce necrotizing enterocolitis, and to prevent fetal death. Remember, those 4 points of steroids are really important, and you got to know those because people want to know, if I take these shots of steroids, what is it really doing for my baby? Well, it's doing 4 really, really good things. And the price of it is there's very little risk unless you're like an out-of-control diabetic. There's really no major issue. How do you diagnose IUGR? It's overall, it's less than the 10th percentile. To me, it's the biggest issue is the abdominal circumference, which is the single best measure to detect IUGR. When the abdominal circumference is lagging, then you got to raise that red flag and say, let's follow. If the abdominal circumference is down to the 12th percentile and the other parameters are at the 50th, something's not right. See her back in 2 to 3 weeks. Look what the umbilical artery Doppler shows, and do serial measurements, as I said. And the amniotic fluid certainly is an important marker as well. The transcerebellar diameter, we've already talked about this. This is a good thing that will help with, especially in people that may present late and you're unsure, their growth is off, you're not really sure. But this measurement is spared in IUGR. So the transcerebellar diameter is going to be normal. One of the things that comes up is always about aneuploidy. So do a good anomaly scan. Look at your anatomic survey. Look for the markers for aneuploidy. Abnormal skull contour, thoracic shape, or disproportionate shortening of the long bones can indicate what? Skeletal dysplasia, right? A skeletal dysplasia, the first thing you should think of is a femur length, which is 5 millimeters below the second standard deviation. So think the first thing, if a femur length is really, really short, because most skeletal dysplasias, not all, but most, affect long bone growth. Viral infections may be nonspecific, but it could include echogenicity and calcification in organs such as the brain and the liver, and then there's microcephaly as well. So remember, in that differential diagnosis, viral infection is there. To diagnose it, we use a combination of biometry and Doppler. We're looking at umbilical artery Doppler, as we already talked about. I'm not going to go into this too much, but any one of these ratios, we use the pulsatility index, which is S minus D over the time-weighted average. Again, a pulsatility index of less than 1.3 by 30 weeks is abnormal. There's not enough diastolic flow there on average, and therefore, that's a patient that you want to follow very closely as a sign. An abnormal umbilical artery Doppler indicates increased placental what? Resistance. That is correct. Here's the umbilical artery Dopplers, again, going from normal to absent. What happens in the middle cerebral artery is just the opposite of what happens in the umbilical artery Doppler. It goes from a very little flow, which you should have, to this opening up or this cephalization in the middle cerebral artery. This middle cerebral artery Doppler is very abnormal. This is wide open. This baby is trying to protect its brain by opening up its middle cerebral artery Doppler, and that's called cephalization. The venous flow as well is abnormal. This is really where babies are getting sick, is the ductus venosus. Systolic wave, your diastolic waves, and then your A wave, which is the bottom here. If your A wave is above this baseline, you're generally okay and you're not going to die. If your A wave is below the baseline like this and you're in the third trimester and you're growth restricted, you got about 1 to 2 days to live, because this is a marker of impending fetal demise. And this is where you have to deliver. Now, what if, our recent case at our hospital, a baby was 24 weeks, barely 400 grams. We had it at 390 grams, 4 weeks undergrown, abnormal venous Doppler. What do? Tough situation. You got to talk to patients. If this is a baby that's going to be severely compromised, do you want to let your baby just pass away in utero? Do you want us to deliver your baby knowing that there's a risk of a high risk of neonatal demise, and certainly a risk of other things such as infections or aneuploidy, and then the risk of classical C-section. And so, this is an hour-long discussion with people, but you got to go through that, and you have to tell people, are you potentially willing to raise a very compromised baby? I think that's the most important question, because I don't think people on average realize what they're up against. They have no idea what they're up against in that setting. Invasive testing, you can do testing, amnio, centesis, karyotyping, reflex microarray, CGH, or what we call our SNP or SNP microarray, viral polymerase chain reaction. Trisomy 18 can present with an unusual combination of growth restriction and poly. And in fact, this is a good slide that looks at the combination of IUGR, an anomaly, and polyhydramnios, and what's the risk of an abnormal karyotype when you see all those. So when you see growth restriction, number one, think of, are there any other anomalies? Is there polyhydramnios? And then keep this slide in mind. Because if you got all three, if you got IUGR poly, which is a weird combination, and I always think of trisomy 18, and you have an anomaly, your risk of an abnormal karyotype is about 50%. So how do we do this? We follow them. The AC between the 2nd and the 10th percentile, I think this is right out of Gabby, actually. And then you do your anatomic survey, the amniotic fluid, and you have your differential diagnosis. You're doing your Dopplers. We don't really do a cerebral to placental ratio anymore, but we just look at all of those, the middle cerebral, the ductus venosus, and the umbilical artery together. And then we either try to make some decision, is this a sick baby and there's placental insufficiency, or is this just a constitutionally small child? You're going to be testing them with non-stress tests and all the above. Our screening, maternal history, a prior growth-restricted baby, there is a risk of it happening again. Our screening that we've already talked about with our quad screening or our sequential screening, our first trimester, I think the two most important are the dimeric inhibin A above 2.0 and a PAP A in your first trimester below 0.42. Seem to be what Lorraine Dugoff from the University of Colorado tells us are the best serum markers that tell us about these things. The uterine artery Doppler, to me, is the first thing that goes awry when you look at screening tests. You want a screening test that tells you early in the process of the disease phase that something's not good. So again, the NST is not the best screening test because that goes awry very late. The uterine artery Doppler, a lot of controversy about the uterine artery Doppler. Does it predict preeclampsia? Does it predict adverse pregnancy outcomes? Does it predict IUGR? Well, I think it predicts severe disease better. It certainly doesn't predict mild preeclampsia or mild IUGR. But in the cases that are going to go bad, this is a good screening test for the bad cases, so to speak. Any preventive strategies that may help? Low-dose aspirin. There's been a good article recently that looked at if you start low-dose aspirin before 16 weeks, it can have a significant impact on reducing the risk of IUGR. Maternal hyperoxygenation, no. Elimination of stress, drugs, yeah, you want to talk about stopping smoking, stop using drugs. Chronic malnutrition, that in patients with chronic malnutrition, improved fetal growth has been reported with increased TPN. So the management of these kids is serial ultrasounds, follow their growth, institute antepartum surveillance, do their Doppler flow studies, and that really helps out. So when we in our unit see a baby with IUGR, we're doing non-stress tests and fluid checks, but at the time of their fluid assessments, they're always getting at least an umbilical artery Doppler. If the reason we're testing them is IUGR, they're getting an umbilical artery Doppler. I think that's really important. You should also consider hospitalization if things are really bad. If we hospitalize a patient with absent or reverse end diastolic flow, bad placenta, IUGR, we're going to do daily testing. And once they've stabilized out and we know they're okay, the question is, can you then let them go, or can you follow them as an outpatient? Here's a good study that looked at which parameters go abnormal the further you go. And I'm sorry, I don't think this comes out in color in your handouts. But again, the biophysical is the latest thing to go awry before these babies die. And then it's the ductus venosus and the umbilical vein pulsations. Those are venous Dopplers, which tells us how the baby fills its heart. If the baby is that sick that during diastole it can't fill that heart, this baby is sick. Unfortunately, again, that's a late finding. So the first thing that will go awry is the umbilical artery, and that will tell you that this is some child that you need to keep in mind. The importance of venous Dopplers, as a kind of my mantra here this morning, is that abnormal venous Dopplers have the strongest predictors of stillbirth, and the likelihood of stillbirth increases with the degree of venous Doppler abnormality. Ominous venous Dopplers include the absence or reversal of that A wave in the ductus venosus, which I showed you, or, and I didn't show you this, but umbilical vein, which is easy to do, to put a Doppler gate across the umbilical vein and look for pulsations in that waveform. Very ominous. The risk for acidemia and stillbirth are highest with the following: repetitive late decelerations observed in association with oligohydramnios or anhydramnios, BPP of less than 6, ductus venosus, reversal of the A wave, or umbilical vein pulsations. And here's a slide that kind of just puts all of this together and looks at early findings, again, uterine artery, and then you start with your umbilical, your brain sparing, and then late findings, absent or reversed end diastolic flow, your reversal of A wave in your ductus venosus, and your pulsatility in your umbilical vein, And then at the end, you get into things like your NST, your biophysical. Again, the NST and the biophysical are very, very late findings. Timing of delivery, I think there were studies, the GRIT trial that looked at this is really important. And actually, the latest editorial suggests it's really not that important because once the baby's growth restricted, there is a risk that they may have, problems after they're born. So we used to really think it's so important as to when to deliver these kids. But again, I think between 23 and 26 weeks, here's how I strategize it out. A growth-restricted baby is periviable. The parents need to be aware that despite maximum management, their mortality is in excess, it's very high, and the management is frequently individualized. You got to get your neonatologist, you got to get the parents involved, MFM, you're the OB, you got to be there. You all got to meet together. You got to have a multidisciplinary meeting. So you got to call an antenatal alert or a perinatal alert or some kind of meeting at 4 o'clock in the afternoon where everybody gets together and says, what are we doing here? Because I don't want to say, well, the neonatologist said this, and you said this, and he said this. How about we all be together in the same room and talk about it together? Right? Then it's not a he said, she said thing anymore. What about if you're between 26 and 34 weeks? It should be based on evidence of fetal compromise when an attempt to complete steroids. After 34 weeks and you got an IUGR baby that's pretty sick, I think your threshold is much, much less. And certainly by 38 weeks, generally in our hospital, if a baby is truly IUGR, abnormal Dopplers, they're going to be delivered by 38 weeks. That's generally my recommendation. Can you deliver them, intrauterine transport. If you're not in a facility that can handle these kids, make sure that they're transported. The route of delivery is determined by the severity. If you think that if this baby, realistically, she's a prime, she's an unfavorable cervix, generally most people will either say, look, we'll give you 12 hours and see what happens, or you know what, let's just see what you are on the monitor. If you're already having late decelerations on your NST, you know what, this induction's going nowhere. Let's just go to the OR and have a baby. I think we're all fine with that. I don't think that that's an issue. And lastly, gestational programming. Remember that all this programming can have effects when you become an adult. And paradoxically, infants that were born growth restricted have the increased risk of having metabolic syndrome as they grow up, i.e. obesity, hypertension, and diabetes. So what happens in utero impacts fetal development and alters a diversity of adult regulatory mechanisms, which generally come together as the metabolic syndrome. So if you're IUGR, unfortunately, you're at risk for cardiovascular disease as an adult, and that's important. So a standard definition of IUGR, less than the 10th percentile. The differential diagnosis for symmetric IUGR, aneuploidy, viral infections, syndromes, or worsening asymmetric IUGR. 3 maternal and 3 fetal risk factors associated with IUGR. I think you guys all know that, right? What is the adult consequence of IUGR? Metabolic syndrome is a good answer. Just think of hypertension, diabetes, obesity. Which Doppler parameter best predicts stillbirth? Venous Doppler. Umbilical vein or the ductus venosus. And what is one preventative strategy early on that may help you prevent IUGR? Low-dose aspirin, absolutely. Recent article that looked at that, about a 50% risk reduction if aspirin was started less than 16 weeks. Okay, one more to go, guys, and I'm done. Yes, question? In theory, I do. I mean, I always look at the abdominal circumference. To me, that's the most important thing out of all these. On a test question, that's not the answer, though. The answer is the overall growth of less than the 10th percentile. Oh, yeah. I mean, if your AC is around the 10th percentile, yeah, I'm concerned. But we just do percentage. The computer just spits out a percentage that says where are you at. for what gestational age you're at. And again, it goes back to dating. But an AC at the 10th percentile, look at the femur length also, right? True asymmetric IUGR, the femur length should be decreased a little bit, and the head should not. This is head sparing IUGR, right? So look at the head, look at all your parameters. But an AC is the first sign that something's not right. So when you look at how these babies get sick, to me, I always tell patients it's a 5-step process. First step, AC is lagging. Step 2, umbilical artery Doppler abnormal. Step 3, middle cerebral artery Doppler abnormal. Step 4, venous Doppler abnormality. Step 5, non-stress test biophysical parameters abnormal. 5 steps of sickness, but the AC is the first thing that should clue you in. And that's the baby you should follow. You cannot give up on that baby. You got to keep following it. One more to go. Hypertension. Guys okay? Am I doing okay? Is this too much, or is this all right? You guys are okay? Okay, good. One to go. Hypertension, second leading cause after pulmonary embolism of maternal mortality in the United States. Accounting for almost 15% of maternal deaths. It's a big issue right now, maternal mortality. We got to remember that we are about moms and we're about babies. We're not just about babies, we're about moms. It can affect up to 6 to 8% of pregnancies. Potentially lethal maternal complications, notably it's associated with abruption, DIC, cerebral hemorrhage, hepatic failure, renal failure. It's the most significant unsolved problem. 6 to 8% overall. What is the risk of preeclampsia? About 3 to 5% overall. And eclampsia, very rare. But you'll get an eclamptic if you do about 3,000 to 4,000 deliveries in your hospital. You're going to see a couple of eclamptics every year. And you got to know how to handle that, and we're going to talk about that. What is the strengths of association of preeclampsia with all these risk factors? Well, I think any odds ratio greater than 3 you should really look at. Okay, so preeclampsia in a prior pregnancy, that's important. What about in a prime? Nah, not so much. 2. Multifetal, well, you say, well, you got a bigger placenta, you're at risk for growth restriction, and you're at risk for preeclampsia. But when you look at the studies, the odds ratios are still pretty low. Chronic hypertension, not so much. Pregestational diabetes, big. Vascular diseases such as lupus, big. Nephropathy. Remember, a test question is what is the creatinine level you're worried about for someone that has, say, chronic renal insufficiency, lupus, your kidneys are under poor control. What creatinine is that key number that says this isn't good? Maybe we shouldn't be conceiving at this point. Creatinine of 1.5. Yeah. Creatinine of 1.5 is a bad number. When you look at ACOG's opinion paper or expert opinion paper on chronic renal disease in pregnancy, 1.5 always stands out. That's a number that is really, really going to lead to blood pressure issues. Thrombophilias, again, not so much. Homocysteine, this is based on really few patients. Obesity, especially BMI of 35, over 3 to me. And then abnormal markers we talked about. And again, remember I mentioned before, it's only really when there's 2 markers that are abnormal. And this slide bears that out. That it's got to be really 2 markers to say, woo, this is somebody I got to watch. So gestational hypertension, as you know, these definitions, is the development of blood pressure during pregnancy or the first 24 hours postpartum without other signs or symptoms, no proteinuria, blood pressure returns to normal, 140/90. It has to occur on 2 occasions, at least 6 weeks apart, but within a maximum of a 1-week period. So you can't say, I did it 2 weeks ago and your blood pressure was up and then it was normal and now it's back abnormal and it was 2 weeks in between. No, that doesn't cut it. It's got to be relatively close to each other. And it has to occur on at least 2 occasions, 6 hours apart. So a person that comes to the labor room, she's nervous, she's scared, her blood pressure's sky high. Okay, that's 1 blood pressure. Can we make sure that we did it twice in a row and we live by the rules we've set by, that we're going to live by? Yes, let's do that. Let's live by rules. Likelihood progression to preeclampsia depends on the gestational age at the time of diagnosis, with a higher rate of the onset of hypertension, higher rate of onset of hypertension is before 35 weeks. So as you look at this, this is very important as to when it occurs as well as to the risk of the development, as to the progression toward preeclampsia. Preeclampsia, I think we all know this definition, but let's just go through it. Blood pressure 140/90, either or after 20 weeks, not at 18 weeks. 2 occasions, 4 to 6 hours apart. I use 6 predominantly. Protein greater than 300 in a 24-hour urine collection, greater than or equal to 1+ dip, and that can be on 2 occasions, 4 to 6 hours apart, with no evidence of urinary tract infections. We know that dipped urine correlate poorly with the amount of protein in the 24-hour urine collection. I wrote a paper when I was a fellow that looked at this and said that, remember, preeclampsia is a vasospastic disease, that it's kind of comes and goes. It's like lightning that comes and goes. So dipping urine isn't probably the way to do this. It's a video. It's not a snapshot. It's not a picture. It's a video. And you want a video. Now, a good study that someone did was looking at 12-hour urine collections versus 24-hour urine collections. And that was actually showed no difference. So maybe this 24-hour urine collection can be substituted with a 12-hour collection. I'd like to see that replicated, but anyways, that's how we diagnose it. And severe preeclampsia, everybody knows. I'm going to just hold questions till the end because I got to get through this, and I only have about 10 minutes, and I got a lot of slides here. 160/110, 20 weeks, after 20 weeks, 2 occasions, 4 to 6 hours apart. Proteinuria, depending on who you read, 2 grams or 5 grams. I think in the national working papers, it was 2 grams. Most ACOG will say 5 grams. Either way, if you have 3 grams of protein, it's bad. So let's try to come up with some common goals here and say, you know what, whether it's 3 grams, let's not argue whether it's severe preeclampsia or not. The serum creatinine greater than 1.2 is a good test question to say, what creatinine level do you consider severe preeclampsia? Now remember, before I said, what was the creatinine level where you will say that a woman's pre-pregnancy creatinine is bad, she's got lupus, things are out of control, and that's going to lead to bad outcomes. That was 1.5. What's the criteria for creatinine to say you're severely preeclamptic? It's 1.2. Let's not confuse those two. Thrombocytopenia, microangiopathic hemolysis, elevated LFTs, persistent headache or visual disturbance or epigastric pain. So of course we're going to give them some Tylenol, we're going to give them some Tums. A common theme I've seen is people complain of heartburn. And they say, I have heartburn and I'm 36 weeks pregnant. Have you had heartburn the whole pregnancy? No. Where's your pain? It's right there. Well, what's right there? Your left lobe of your liver's right there too. And I've seen a couple of patients in HELLP syndrome that actually told the initial doctor that I just got this heartburn, I got this pain. So don't confuse heartburn. A common call over the phone, I got heartburn. Well, maybe it's something more than heartburn. Pulmonary edema, IUGR, or oligohydramnios. Eclampsia, seizures that cannot be attributed to any other cause. Grand mal may occur up to 3 weeks postpartum. 10% of seizures occur before proteinuria develops, so you got to be careful. Chronic hypertension, present before pregnancy, mild, systolic greater than 140, diastolic greater than 90, severe, systolic greater than 160, diastolic greater than 110. The use of antihypertensive medications prior to pregnancy. Hypertension's got to be, if it's chronic, it's diagnosed before 20 weeks, and it's got to persist for more than 6 weeks afterwards. So in all this, probably one of the most important things is to see a person in 3 months after a pregnancy. What is your blood pressure at that point? How are you feeling? Is there a need for medication? Did we slowly take you off your antihypertensive and things got better? And that's really important for her long-term care because women with preeclampsia are at risk for cardiovascular dysfunction, especially if you get preeclampsia in your second pregnancy. That seems to be a real marker for down the road cardiovascular dysfunction. That woman is going to be at risk for problems later in her life. With superimposed preeclampsia, the only real way is to look at protein. You can say, a sudden increase in protein, a sudden increase in blood pressure, or evidence of HELLP syndrome. But remember, all this criteria about this increase in systolic blood pressure of 30 or diastolic greater than 15, none of that is is in today's world. So blood pressure, how many people here have been called by a nurse saying, well, her blood pressure on her left side is, this, on her right side it's this. Okay, let's stop with the left-sided and right-sided blood pressures. That's not the way we check blood pressures. We check them either in sitting with your arm at the level of your heart or in the semi-Fowler's position in bed. All right? The rise of 30 systolic and the rise of 15 diastolic has abandoned. However, I still use that to say, you know what? Maybe that's something important to watch. Some women have baseline blood pressures of 90/60. My wife, she's got she can't even feel her pulse hardly. She's got a very low blood pressure. So yeah, no, you're not going to meet criteria, but that may be something to say, let's watch things closely. Edema is not a criteria anymore either. What about proteinuria? A sign of worsening hypertensive disorders. It may be persistent because of fluctuations. It may not develop till late in this process. What's important that protein or hypertension or proteinuria may be absent in up to 10 to 15% of women who develop HELLP syndrome and up to 38% of women who develop eclampsia. HELLP syndrome is a very, very, it's a tough one because it doesn't, a lot of times it just doesn't follow any rules or regulations, and it can be so many different variants of that. Okay, pathophysiology. We know that it's a systemic syndrome with both maternal and fetal manifestations. The cause of this is not known. Many consider that it's the placenta, right? It's the S-FLIT, it's the VGRF. It's the placenta that causes this. Okay, well, when you take the placenta out, usually everything gets better over the course of a couple of days. So clearly, yes, delivery is the only definitive cure for this disease. Again, this secondary, this failure of this wave of trophoblasts, which we already talked about. There are other thoughts too, though, including prostacyclin, decreased in prostacyclin, which is the good guy, and increased in thromboxane, which is the bad guy. Vasospasms, immunity may play a part. When you think of why does a first-time mom have higher rates of preeclampsia, is it that her body is just getting used to being pregnant? Well, part of that fetus is mom, so mom recognizes herself, but what it doesn't recognize is dad's antigens that are expressed in the fetus. What about if there's a new father of the baby? How many patients do you see in today's world? 14 years since I was last pregnant. First question, is it a new father of the baby? Yes, it is. Okay, that's fine, no problems. But let's put that on our little risk factor profile that says, ooh, this is a 14-year interpregnancy interval, which does increase the risk of preeclampsia. And this is a new father of the baby, which may increase the risk of preeclampsia. Let's put that on our list of things to just our little risk factor watch list, so to speak. And then endothelial activation. And actually, the latest studies that have looked at is complement activation. And so they're coming up with some of these complement activator inhibitors that may actually help with this prevention. The manifestations, remember that cardiovascular in pregnancy increased, with preeclampsia, increased SVR, increased cardiac output, and therefore increased blood pressure. Why? Because blood pressure equals cardiac output times your SVR. There's increased permeability in your capillaries, which leads to pulmonary edema, and they can experience pulmonary edema at much lower wedge pressures than other women, and that's this increase in your permeability, and they have lower oncotic pressure. That's the pull pressure that keeps those proteins in the vessels. So you're a setup for pulmonary edema. Your volume status is lower than that of normal gestation, and that's evidenced in hemoconcentration. So always look at their H&H. If their hemoglobin's over 13, there's a problem. They're concentrated. They're volume constricted. The test question that you may see is called, what is the renal problem? It's called glomerular capillary endotheliosis. And that is glomeruli in your kidney that are enlarged and swollen, but not hypercellular, primarily the result of hypertrophy of the intracapillary cells. mainly endothelial but mesangial cells as well, which encroach on the capillary lumina, giving the appearance of a bloodless glomerulus. Glomerular capillary endotheliosis, for what it's worth, it's in all the books. Lou Weinstein that wrote about these things way back in the 1960s. If he was your board examiner, he would ask you that question, I guaranteed, because I know him, and good guy, but he wants to know what the classic renal abnormality is. Anybody use uric acid? We try to stay away from uric acid. It shouldn't be used. ACOG doesn't recommend using uric acid. It can be a marker for renal dysfunction. Again, it just may clue you into that, but hyperuricemia, it is associated with renal dysfunction. A cutoff of 5.5 is only 69% sensitive and only 51% specific. And to me, I don't use it at this time. Hematologic thrombocytopenia is severe, the most common found hematologic abnormality. The cause is unclear. Fibrinogen levels are unaffected. Antithrombin 3 is usually a little bit lower. Your liver lesions, periportal necrosis, ischemic changes. If you have right upper quadrant pain, 30% chance of a subcapsular hematoma. And if you have a subcapsular hematoma, you got a 30% chance of dying. So don't blow off right upper quadrant pain. It's really, really important. And you can see an increase in your LFTs. Your CNS, you can have cerebral hemorrhage from severe hypertension, cerebral edema, retinal artery vasospasm and detachment, headaches, scotomata, brisk reflexes, clonus. Everybody check for reflexes and clonus. You should be. We should always be checking for clonus. Okay, now, can we predict preeclampsia? Oh, there's thousands of tests that have tried to predict this. To me, the best test is to look at a woman's blood pressure at 16 to 18 weeks. Did you undergo that second trimester drop in your blood pressure? And if you did, that's a good sign. That means things are kind of working normally. If you didn't and your blood pressure stayed the same or is actually higher now, that's again someone, I'd put that on their little risk factor list. Did not undergo a second trimester drop. Remember, blood pressure should be normal, second trimester drop, and then back to normal. If you didn't undergo that, keep that in mind. Uterine artery Dopplers, again, can predict the severe cases. They do not predict the mild cases. This is a nice uterine artery Doppler, a lot of diastolic flow. Here's the two iliac arteries. Here's the uterine crossing over. You put your Doppler gate right on that vessel right there, and you'll get this waveform. It's easy. It's an easy test to do. And again, this says the same thing, that basically it's good at predicting the severe cases. It's not good at predicting the mild cases. A meta-analysis that looked at aspirin in women that were known to be at high risk for preeclampsia because of an abnormal uterine artery Doppler that seemed to help. The odds ratio was 0.55, so that means there's a 45% risk reduction. The number needed to treat, which everybody kind of wants to know now, a number needed to treat was 16. Prevention, we've looked at zinc, magnesium, salt restriction, protein restriction, fish oils, vitamin C and E. Those studies have clearly failed. Diuretics, nothing really seems to have helped. Cochrane review, calcium supplementation was one thing. It was associated with reduced hypertension, particularly for those at high risk. The benefit for calcium supplementation for preeclampsia prevention in women with low dietary calcium intake remains unclear. There's just some good articles, but in the largest trial to date, there was no risk reduction. So I generally do not recommend calcium supplementation. Low-dose aspirin, again, this is an older slide, but the newer article that just came out, again, if you started low-dose aspirin before 16 weeks, your risk reduction for preeclampsia was not 17% like this study shows. This is the Cochrane review, which has not been updated yet. But if you started it below 16 weeks, your risk reduction was about 53%. So if you're going to use anything to try to prevent it, use low-dose aspirin and start it early in people that you deem at risk. Management depends on severity and gestational age. What is your diagnosis? Hospitalizing people is a good thing to figure out where you stand. What is the diagnosis? Is it mild preeclampsia? If it is, we'll continue to follow them and watch them through 37, maybe 38 weeks and then deliver. If it's severe preeclampsia and you're over 34 weeks, you're generally going to be delivered. If you have HELP syndrome, if you're stable HELP, you may want to buy a day or two to get steroids on board. If you feel that things are really bad and things are changing quickly, you're going to deliver the fetus. You also want to look at the fetus to assess for IUGR, beta-methasone, control blood pressure. We'll go through that. Here's a nice slide that talks about the management of preeclamptics and how to do this. So with severe preeclampsia and greater than 34 weeks, we are going to deliver. You can manage people conservatively if your diagnosis of severe preeclampsia was based on blood pressure only, based on proteinuria only, or by IUGR only, and you're under 32 weeks. I think that's reasonable. Again, you'd probably want to you're going to keep these people in the hospital if they have severe preeclampsia. And to me, I think preeclampsia is supported more by the first statement I said, which this is a systemic problem. This can affect a whole host of things. You know, your eyes, your liver, your kidneys, your placenta, your baby, everything. And again, I'm very cautious to say that, you know, babies that are stressed out that have IUGR have accelerated lung maturity because, again, I think that those studies are very conflicting. So I treat them just like anybody else, and we're going to give steroids to accelerate fetal lung maturity at the first drop of a hat that says, I'm worried about this mom. Well, we're worried about mom and baby, so we're going to accelerate lungs. When you look at expectant management of severe preeclampsia, does it really, does it buy you much? It doesn't really buy you much, no. It buys you a couple of days. So you're going to keep them in the hospital, watch them close. They're going to be, if you're really worried, you're going to be on mag sulfate. You're going to be controlling your blood pressure with hydralazine or labetalol. And here's our algorithm for managing severe preeclampsia. Magnesium sulfate's the drug to choice. It's better than Dilantin. That's been proven. Is there a benefit to treating women with mild preeclampsia? There's a lot of studies. You know, the MAGPIE trial probably stated this best, that there probably is a little bit of a benefit in treating someone with mild preeclampsia to put them on mag sulfate. But that's kind of the watershed area that's a little bit unknown. Certainly, it's a benefit to put them to use mag sulfate in people with severe preeclampsia. It's the drug of choice over Dilantin. Test question, what is the condition that's contraindicated for mag sulfate? The answer, myasthenia gravis. Know that. That's a common test question. It blocks calcium influx. It's cleared by the kidneys. So severe preeclamptics, again, you got a creatinine of 1.3. Be careful. Maybe use Dilantin. Maybe go over and check on the patient every 4 hours. MAG levels. Who uses MAG levels? Anyways, check your reflexes. MAG levels, common question, MAG levels, 4 to 7 is normal. EKG changes at 5 to 10, patellar reflexes decreased at 10, respiratory depression at 15, and cardiovascular collapse at 25. Neonatal hypotonia. Aha, test question. What is the antidote to reverse MAG toxicity? It's right there. 1 gram of calcium gluconate. And how's it given? IV. Very good. So we're going to control hypertension. We're going to use labetalol, nifedipine, have fewer side effects than hydralazine seems to be a really kind of a harsh drug. It has really quick, hard effects. Drugs used to treat hypertension, know this. This is really good. You need to know these algorithms. Hydralazine, it's 5 to 10 every 20 minutes, maximum dose 30. Labetalol, 10, usually 10, 20, 40, 80, maximum dose per hour, 220. Know these numbers right here. What is your maximum dose per hour? Those are good test questions. Nifedipine we don't use to start, we don't use it orally. We're going to use something IV. Nipride, the test question here is, What is the toxicity? If you need to use IV nipride, what is the potential fetal toxicity? Cyanide toxicity. Nitroglycerin, know what nitroglycerin, I would ask a question and say, how does nitroglycerin work? Is it a venodilator, an arterial dilator, or both? It's a venodilator. And you can use nitroglycerin. We use it more, to relax the uterus problems. Anesthesia, get your anesthesiologist involved. You may need monitoring. You may need invasive Swan-Ganz catheter or a right-sided catheter. If you have oliguria, think of it as in 3 parts. Is this a volume issue? So you may want to give a little volume. Afterload reduction. Nifedipine works very well, especially postpartum. Is this heart failure that you're not perfusing your kidneys? Is an echo needed? Or a very common in young women are pregnant, renal artery stenosis. And then postpartum, remember that fluid all comes back, and this is where you're at risk for pulmonary edema. The other thing I've seen over my career is that nifedipine really seems to work to help lower their blood pressure postpartum with that afterload reduction. And then again, watch for some of these, the classic postpartum dilated cardiomyopathy. Who are those? They're the obese women with chronic hypertension and superimposed preeclampsia. Get an echo if you're worried. The recurrence risks are stated. There is a recurrence risk, whether it's if you had HELP, whether you have recurrent HELP or recurrent preeclampsia. It's all stated there. But know that if you had it in a prior pregnancy, it's a problem. The imitators of preeclampsia, just a couple of things I want to touch on. I'm late here, so I want to get done. TTP, what is the classic pentad of TTP? You all should know this. Thrombocytopenia, microangiopathic hemolytic anemia, neurologic abnormalities, fever, and renal dysfunction. The pentad is only seen in about 40% of patients. But know that. That's a good test question. The pentad of TTP. Acute fatty liver is another imitator. And that usually presents with a couple of things, an elevated ammonia level and hypoglycemia. When you do a CMP, you do an SMA-12, whatever you call it in your hospital, you're going to look and say, her sugar is only 55. What is the bilirubin that's associated with HELP syndrome? What's elevated, direct or indirect? Indirect. What is the bilirubin level that's associated with acute fatty liver, direct or indirect? It's direct. So it's a big difference. These people, AFLP patients, are going to be jaundiced. HELP syndrome patients are not going to be jaundiced. There's a difference there. And then lastly, with the TTP, also these new tests, the von Willebrand's factors, multimers, and the Adams TS13, those are elevated, but that's kind of new stuff that's coming out. So we talked about acute fatty liver. HELP syndrome, you guys know about. The classic findings for HELP syndrome, abnormal peripheral smear. For HELP syndrome, remember, there's a lot of variants. But the key is that you need some form of hemolysis to make the diagnosis. And that can be either with an abnormal smear, an elevated indirect bili, a low haptoglobin level, or an elevated LDH isoenzyme 1 or 2. And that's HELP syndrome. And there's a lot of different things that can look like HELP syndrome. But again, HELP syndrome is a difficult one because there's a lot of imitators. And it can be ELP, it can be HEL, it can be LUP. But you can't be LUP because you need the H. You need hemolysis to make this diagnosis. And you should go transfuse platelets if your platelets are less than 20,000. We don't use dexamethasone with HELP syndrome because it's been shown to help with your laboratory evaluations, but does it really help in a clinical sense? And the answer is no. Lastly, eclamptic seizures can occur. Do not run to the OR when someone's having an eclamptic seizure. An eclamptic seizure is bad. Let's control the seizure first, and then let's evaluate the baby. There is an associated risk of placental abruption with an eclamptic seizure. And people that seize are at risk of seizing again. But do you have to do an emergent stat section? No. Do not go to the OR with an unstable patient that's seizing. Let's do everything we should. Control her airway. The seizures will break. Yes, you can give them some benzodiazepines or whatnot. Seizures are going to break on their own generally. You can do cerebral imaging to look for infarcts or bleeds, and there is a long differential diagnosis. But for the most part, it's eclampsia, going to be eclampsia till proven otherwise. And there's a lot of other issues, but the key is establish their airway, try to prevent it, put them on mag, sulfate, ensure oxygenation, but don't run to the operating room and try to do a stat section on an unstable patient. Mag is the drug of choice. Dilantin is a good alternative. They can reseize again. Mag only. They can about 10% risk of having another seizure. Bradycardia can ensue, placental abruption can occur, and you got to keep that in mind afterwards. But you should give it some time to let baby recover. And I think there's just a couple of slides on chronic hypertension, which I'm going to stop because I think we should stop because we're overdue. Keep in mind your drugs, aldamet, the labetalol, in women, avoid it in women with asthma or CHF. Remember that labetalol is both an alpha and a beta. That's a good test question. And methyl dopa is CNS acting. Okay, last question, I'm done. List specific criteria for severe preeclampsia. I think you guys all know. We went through that. In which chronic disease process is magnesium contraindicated? Myasthenia gravis. What is the pentad of TTP? Let's state them all together. Yes, thrombocytopenia, microangiopathic hemolytic anemia, renal dysfunction, CNS, and fever. Excellent. Very good, guys. The regimen for hydralazine and labetalol, you know hydralazine. Let's go through that regimen. It's generally 5 to 10. How often? 20. And how much total over that hour? 30. Excellent. And how about labetalol? What's your regimen? Excellent. Over how much? Can you give total? 220. Fantastic. Very good. A low serum glucose and an elevated ammonia level is a hallmark of what disorder? Fatty liver. Elevated direct or indirect with help? Indirect. With fatty liver, indirect or direct? Very good. And what toxicity do we see with nitroprusside? Cyanide. Thank you, guys. I wish you all the very best.
All right, so we're actually not talking about Urogyne. We're going to talk mainly about surgery, intraoperative, postoperative complications first, then we'll talk about perioperative management in the second series. Just a little housekeeping stuff. I do have some, I do work for some companies. None of that comes into these two talks, okay? We're going to talk about common intraoperative, postoperative complications you're going to encounter and that they like to test on. They do like to test on complications. It's one of the things they love to hit on during the exams. So intraoperative complications, please, this is not anything to do with the exam, but please be calm and rational. You have no idea how many times I come in and it's like someone's running around with their head cut off. So just, take it easy, calm down, just a few seconds. Rational heads will usually solve the problem a lot faster than, craziness. So we'll start off with something light like bowel injuries, okay? Small bowel injuries and large bowel injuries, okay? You can have both kinds. Obviously, if you recognize a small bowel injury or large bowel injury, you'll deal with it. We'll talk about how you deal with it. But I'm going to talk right now about unrecognized or occult bowel injuries. Small bowel injuries are much more insidious than large bowel injuries, okay? So in the vignette you're given during your exam, if you have a patient who is slowly getting sick over the span of 4 to 7 days, and that's indicative of a small bowel injury. A large bowel injury, which we'll talk about in a moment, they get sick very, very fast. It has to do with the bacterial load of the injury. Small bowel has a very low bacterial colony counts, whereas large bowel has very large bacterial colony counts. Small bowel injuries are actually probably much more dangerous because of that insidiousness. People don't usually get sick until they're about to crash. So it has to do with a very slow, insidious release of endotoxin that starts to leak, cause your small vessels to leak and leak and leak and leak, and the organ dysfunction that will result in them crumping shows up at the very last possible minute. So insidious onset in the vignette is indicative of a small bowel injury, okay? They often don't get diffuse peritonitis because the body will wall off the infection. The omentum will wrap around the small bowel injury and you'll get localized signs, but not usually diffuse peritonitis. If you do recognize the small bowel injury, immediate transverse closure, okay? The idea of closure is to avoid narrowing the lumen, okay? So when I say transverse, you think about the axis of the bowel. Your in-suture line should be across the longitudinal axis of the bowel. That's how your suture line should end, okay? And I have a picture of that in a moment. You only resect it if it's a really large segment. If you think it's a large injury that you're not going to be able to close transversely, you can resect it. Obviously, most of you wouldn't do that, but you need to know that that's what you would do. And ileostomy or diversion is really unnecessary with any small bowel injury regardless of prep. The colony count is low enough, you don't really have to worry about it. So when we talk about transverse closure, if this is your axis of your bowel and you have a longitudinal incision, you convert it and just close it from here to there so the line ends up being across, okay? That's how you do it. Delayed absorbable sutures are fine on the inner layer. Most people will repair the outer layer. It's a two-layer closure. We'll repair the outer layer with a permanent suture, and that's the more critical layer, okay? Prolene, silk, whatever. It doesn't really matter. There's no right answer to suture for the most part. It's just a matter of a two-layer closure, but this is the key, okay? Transverse to the longitudinal axis of the bowel, okay? Any questions about that? Large bowel injuries, much more acute onset, 24 to 48 hours later. If you don't recognize injury at the initial surgery. These people get high fevers, diffuse peritonitis, really sick within 24 to 48 hours, okay? It's a large bowel injury, all right? So if the vignette gives you that scenario, large bowel, not small bowel. These people are the ones who often get free air on the upright KUB if you were to get an x-ray. The small bowels don't always give you free air. The small bowels, again, very insidious. The vignette might be a little unclear, but large bowel, they'll almost always have free air. Again, if you recognize it, immediate transverse closure. Okay, same principles apply in terms of closing this. Resect it if it's a large segment that's injured. This is a different scenario because the bacterial load is so high. If these patients haven't been prepped, you will often want to have a diversion colostomy placed, and that's to divert the fecal stream to avoid inoculating your repair with bacteria, to minimize the amount of inoculation that's going on. If you have a patient who's having a cancer surgery, radiation surgery, you may want to divert them anyway, even if they're bowel prepped. But if they're bowel prepped, you do not have to divert, as a general rule of thumb. Okay? Do not need a diversion colostomy. All right. Ureteral injury. This is more up my alley. This is the kind of stuff I fix. So you have all kinds of ureteral injuries. You can have a crush injury, transection, thermal, all these. Anything can happen to the ureter, right? We're the number one predator of the ureter. It's because we play there all the time. That's the reason we do it. It's funny. You hear all the general surgeons joke about it. Cut the right ureter, cut the left ureter, all that stuff. But the reality is, every time I've gone in a pelvic case with them, they're like, "Holy crap, that thing's close." So. Board question, total length of the ureter in an average size woman, 25 to 30 centimeters. Classic board question. There all the time, okay? Half of it's in the pelvis, half of it's pelvic, half of it's abdominal, all right? So just keep that in mind. The 25 to 30 centimeters long, half in the pelvis, and by pelvis I mean below the pelvic brim, half in the abdominal cavity, all right? Course of the ureter really doesn't matter for most of you guys in the abdominal wall, but it's lateral to the ovarian vessels until it gets right to the common iliac, and then it goes medial, okay? In the pelvis, the ureter is always, 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 always medial to the ovarian vessels, okay? Another board question, all right? The three most common sites the ureter is injured, okay? The pelvic brim, where those vessels are in close, the ovarian vessels are in approximation. So when you're opening your your perirectal space to cross-clamp your ovarian vessels. You always look for the ureters, trying to find them. The ureter is going to be lower because it's on the medial leaf. It's medial to the vessels. But this is the first place you can get it, okay, where you're cross-clamping your ovarian vessels. Second place you can get it is at the level of the uterine artery. So that's why we skeletonize to visualize the uterine artery, why we hug the uterus when we clamp it. And that's the biggest the biggest way to prevent that injury is elevation of the uterus. Okay, you lift the uterus up with either a talc with a clamp or whatever. The ureter stays behind. The uterine artery elevates. You know, at rest, the uterine artery is 5 to 10 millimeters from the uterine artery. The ureter, that's how the difference between the two. If you put traction on the uterus and lift it up, you can increase that distance by a couple of centimeters, which saves you a lot of injury. So when we started doing LEVHs 25 years ago, a lot of ureteral injuries occurred because we were not elevating the uterus maximally, and we were just clamping, burning, whatever the hell we were doing. And a lot of ureters got injured at that point in time. So elevation is key. The third, and this is probably the most common place I see it, is at the level of the cervicovaginal junction. Okay? This is the uterus. This is below your uterosacral pedicle. When you take that uterosacral pedicle, a lot of people now will take a Haney clamp or some kind of curved clamp and curve under the cervix, try to incorporate the vagina, all that stuff together. If you heel out too much and your heel picks up that lateral tissue, you can grab ureter with that. So if you're going to do that maneuver, just make sure you've cleared off your uterosacral pedicle laterally enough. Check the heel of your clamp before you cut it. Yes? So during vaginal, it's a great question. So the question was, can you avoid injuring the ureter by elevating the uterus in vaginal surgery? And the answer is you can't elevate the uterus. However, with vaginal hysterectomy, when you make your anterior colpotomy, when you enter the anterior space and you're elevating your bladder, you're taking the ureters up with your dever or whatever you're using to retract the bladder. So the key with vaginal hysterectomy is you're pretty much, once you make your posterior colpotomy and or anterior colpotomy, you just have to be very careful and hug the uterus. But once you enter anteriorly, you won. It's almost impossible to get a ureter once you get in anteriorly. Okay? All right, I don't know why I have this slide in a second time, so we'll skip it. Risk factors for ureteral injury is endometriosis, enlarged uterus, enlarged ovaries, PID, malignancy, and previous surgery. All pretty self-explanatory stuff, right? I mean, these all make sense. However, the thing to remember in your practice, 50% of injuries occur in patients with no risk factors. So be vigilant, okay? Be vigilant, very important. Intraoperative recognition is the best. If you can recognize it, you can deal with it, and there's really no morbidity associated with it long term. So if you recognize a crush, ligation, thermal, or kinking injury, all you really have to do for those is place a stent. Leave it in for varying amounts of time depending on what your consultant says, but it doesn't require any kind of cutting, reimplanting, anything like that. Even one that's been sitting in a clamp or a tie for like an hour, you just stent it. It's got great vascular supply. It will heal. Just have to stent it for a while. If you have a transection, you recognize. Okay, if you cut your ovarian vessels and you happen to see 3 vessels instead of 2, one of them is actually there'll be 4 because you see the ureter twice. Then you probably want to fix it. Okay, so look at your pedicles, make sure all the circles add up. All right. If it's at or above the pelvic brim, which is rare in benign gynecologic surgery, you do an end-to-end ureter or ureterostomy. Generally, the board question, this is a classic board question. You have a ureteral transection within 4 centimeters of the bladder. 4 centimeters is the rule. Anything 4 centimeters or below, you reimplant it. Okay, you do a neo-ureterocystotomy. That's the fancy name for reimplanting it. With or without a psoas hitch. A psoas hitch just takes tension off the repair. In reality, pretty much anything below the pelvic brim we're going to reimplant. An end-to-end is very hard to do, even 8-10 centimeters away because you could have a hard time mobilizing it. So, but this is a board question. Within 4 centimeters of the bladder, I've seen this question year after year after year after year. That's a classic one. This is just showing you what a neo-ureterocystotomy is. It's really actually a pretty easy surgery. You open the bladder up, you pop a hole in the bladder, you just drag the cut end of the ureter through, you spatulate it by cutting it, and you just sew it down. I mean, it's not real rocket science. which is, I wouldn't do it if it was rocket science. So, and then you can hook the bladder up to take the tension off if you want to, okay? But this is a pretty easy, this is just, they don't want to ask you how to do it. They don't ask that question. They just want to know that you know when to do it, okay? Delayed onset ureteral injury. These are the ones where you don't recognize it, okay? The symptoms they'll get, fever is a classic one. It's a fever, you don't really know what's wrong with them, they don't look that sick, they just keep spiking temperatures. And it has to do with inflammatory response to the urine in the preperitoneal space. Flank pain is another one. That usually is a sign of obstructive uropathy, so that's the renal calyx dilating. Prolonged ileus, nothing slows bowel down like urine sitting around it, so you'll get a ileus with it. Creatinine is a hard one. Creatinine can be all over the place. If you have a leak, your creatinine can jump up to 7 and 8 because you're reabsorbing it. And these people don't look like they should be 7 and 8, but that is because it's chronic recirculation of the creatinine. If it's obstructed, if they're obstructed, the creatinine may not bump that much at all. Okay, you can knock off one entire kidney, and your creatinine, if it's 0.5 to start with, could go to 0.8 or 1. Okay, in which case you've knocked off half your kidney function, but 1 is a normal number. So creatinine is a hard one, and on an exam, they're going to use that to kind of throw you off. Okay, I would not use that as your measurement on to dictate to you on an exam what you're going to do with it. The clinical vignette's more important. Okay. Watery vaginal discharge, that is a classic thing they show in the vignette. Patient 10 days post-op starts gushing urine from the vagina, or starts gushing, complaining of watery fluid coming from the vagina. They're getting at urine. I almost guarantee it. Okay, if that's in the vignette, watery fluid from the vagina is urine. That's what they want you to. That's what they want you to think. And then hematuria is another one. Persistent hematuria is something. These are signs to watch for. Again, evaluation. If you think you have an injury, you check all these things: electrolytes, beyond creatinine. But again, beyond creatinine, hard to tell what to do with that information sometimes. Imaging, renal ultrasound is a quick, easy test. That will give you a diagnosis of obstruction. You'll see hydronephrosis, okay? If you see hydronephrosis, you know you're obstructed and you got to do something about it. If you do not have hydronephrosis and you still suspect an injury, you think there's a leak, you think there's fluid gushing from the vagina, you have an elevated creatinine, you suspect reabsorption, whatever, then you need to get an IVP. Okay, you need to test them. Yes? CT urogram is another test to do. It's appropriate. The OBGYN boards are not caught up. My guess is they're not caught up to that technology because CT urograms are institution dependent. You have to have a good radiologist and you have to have a third-generation scanner. And so the board exam will not follow that yet. That's probably going to become the standard of care, but it hasn't I'm guaranteed that hasn't happened yet. So. Delayed onset, how do you manage it? It really depends on what the problem is. If you have a partial or complete obstruction, you have a partial obstruction, if you have an obstructed problem, first step is to try to stenting it. Or you do a cysto, you try to pass a stent. Okay, if you can't pass a stent, then you either can choose to do an immediate repair or you can put a PERC, nephrostomy in. Okay, none of you would do this, of course, but you could do it. And the nephrostomy is just to decompress the ureter. But the general rule of thumb, and the other thing is if you have a leakage of urine, you immediately repair it regardless, okay? The general rule of thumb, you repair these as soon as you can, okay? The only real contraindications to immediate repair, if you have really, really massively dilated ureter that makes it hard to reimplant it, then you just put a PERC in to decompress it. But the real contraindications to immediate repair are these: sepsis, hemodynamic instability, coagulopathy. Obviously, these are people you just don't want to operate on because they're sick. So these people, you PERC them, go fix it later. All right, vascular injuries. What I did with this is I kind of picked different vessels that you're more commonly going to see in a vignette to injure. So we'll start with the abdominal wall. There are two epigastrics. This is a classic question they like to get you on. Okay, there's two, superficial and inferior epigastric. All right, the superficial epigastric is one of the three branches of your femoral that comes back up to the abdominal wall. Okay, this is the vessel that you transilluminate. Okay, you know how you stick your camera or your light underneath the abdominal wall and you look for vessels? That's the vessel you see. You do not see the inferior epigastric. That is not the vessel you see. You see the superficial. okay? It's above the fascia, it's in the lateral wall. This is the vessel you always hit during your C-sections that piss you off because it bleeds a lot when you cut it. That's the vessel, all right, the superficial epigastric, okay? Not the most critical vessel to hit if you hit it. The inferior epigastric is the one you do not want to hit, all right? Inferior epigastric, you cannot transilluminate, okay? To understand why, you think about a bird flying across the sun. If it happens to be really high, it does not cast a shadow. If it happens to be 5 feet above your head, it does cast a shadow. It has to do with how far or how close you are from the light source, okay? The closer to the light source, it does not cast a shadow. That's why this does not cast a shadow. You don't see that transilluminated. The most common time to injure the inferior epigastric is in a laparoscopy or in a malar incision, all right? The inferior epigastric comes up. It's one of the 2 branches of the external iliac before it becomes the femoral. It comes up lateral to your obliterated umbilical vessels in the lateral peritoneal fold. Okay, it generally runs about 4 centimeters up, and then it dives under the rectus abdominis muscle, the lateral edge on both sides. Okay, your phalansteal goes a little bit lower than that, so you really avoid it. But if you do a malar where you transect the muscle, you have to make sure you ligate it. Okay, you have to ligate it. Another way to find it on laparoscopy is pretty classic. Here's your umbilical fold. Here is your epigastric. Take a look at the round ligament. See the round ligament coming up and over and exiting through the inguinal ring? The inferior epigastric is always, 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 always medial to the exit of the round ligament. Okay, so if you're looking through an umbilical camera and you look at your round ligament, if you have a really obese patient, you just can't see the vessel. If you go lateral to the round, you'll be fine. Okay, another little trick for you. That doesn't show up on the exam. That's just a little clinical pearl for you. All right. This one, for some reason, they like to ask this question once in a while. I don't know why. I've never actually done it, but they say if you transect the inferior epigastric, you got to fix it. You can ligate it. You can do that laparoscopically. You can take a big hunking harpoon needle and throw it right through the abdominal wall and tie it. You can dissect down to it and get it. One thing, they sometimes will have you pass a Foley balloon through the trocar, inflate the Foley balloon like a 60 cc balloon, pull it up as tight as you can and clamp it to the skin, and that pressure will stop the bleeding, okay? I've never personally done this. However, it does show up occasionally on an exam as an option. So the way it would show up on an exam is they'd give you like 3 ridiculous options and then this option. And obviously you choose this option in the exam. All right, sacrocolpopexy, another vascular injury. The most common vessel injury is the middle sacral artery, okay? That is the board answer, all right? Now I'm going to give you the right answer because that's actually incorrect. The middle sacral artery you can injure, but it's not the most critical that's not the most critical vascular injury in that space. It's the vein. The vein is the critical thing you do not want to injure. If you injure the artery, you know, you could trace that up. It comes off of the back of the aorta. I mean, you could ligate it, and the bleeding stops. The veins will retract into your sacral foramina, and then you're hosed. You can't get to them, so that's a problem. So the real answer for the board exam is the middle sacral artery. Just for you guys so you know what we're dealing with, I'm much more concerned about the veins than I am about the arteries. If you get it, you got to stop it right away. If you get bleeding in that space, you cannot allow it to retract. You got to get on top of it, okay? You can ligate it, burn it, clip it, whatever you want to do. You can use sterile thumbtacks. That's not going to show up on the exam. It's just, you know, I've done that once in my life, sterilized thumbtacks. Bone wax you can do, you know, all kinds of stuff you can do. But the board question you need to worry about is middle sacral artery, all right? Okay, sacrospinous ligament suspension. I can't find a picture of this. I'm sorry, I keep trying to find a picture of this and I can't find a picture of it. If you get bleeding during a sacrospinous ligament suspension, it is not the pudendal. Okay, they're going to want you to say pudendal. It is not the pudendal artery that you injure, all right? It's the inferior gluteal. That's going to be the answer. The inferior gluteal gives a coccygeal branch that crosses over your coccygeus muscle. That's the vessel you tend to injure during a sacrospinous ligament suspension. The way you manage injury to this is you try to ligate it, clip it, tie it, whatever you can do to it. If you can't, pack it. Okay, this is a low pressure artery. It responds very well to packing. Okay, and we'll talk about packing later on in this talk. Oh, we'll talk about it right now. So you ligate it if you can see it, pressure it. Feel free to use fibrin glue, tissue seal, and all that kind of stuff that's out there. You know, I would say in your head, if you're taking the oral boards, know at least one of those sealants in your head. Helps to have it, and that way you can use it. You can try embolization, you cannulate the femoral artery, but it really depends on where the injury is that you're trying to embolize. There's a lot of collateral circulation in the pelvis. Embolization is hit or miss depending on where the injury is. But generally, the rule of thumb is pressure ligation. Packing is very, very, very reasonable, okay? Whenever you guys, most of you are taking your written boards, I know, but when it comes time to the oral boards, if they get you a patient where they're just hosing and hosing and hosing, pack them. Pack them. You'll always win with packing, all right? This question they love to ask hypergastric artery ligation. Almost every exam I've seen, they have one of these. This is the answer. I'll tell you what the question is in a minute. Basically, with hypergastric artery ligation, you basically just cross-clamp the internal iliac artery below its anterior posterior division. So here you have just your aorta, common iliac, external iliac. Here's your internal iliac coming into the pelvis. It divides into your posterior division, which goes to the superior gluteal, etc. The anterior division is the one we deal with most of the time, okay? You want to ligate it below that division. You ligate it above it. There are a few case reports of butt sloughing from doing that. So you really want to go lower. You pass the right angle from lateral to medial under the artery, grab the suture, tie it off. Now the reality is they're not going to ask you how to do it. They may in your oral boards, but they're not going to ask you how to do it in your written boards. What they're going to say is, how does it work? And the answer, it does not stop the flow. It decreases your pulse pressure by 85%. The board question, every year I've read it, they give you decreases pulse pressure by like 20%, 50%, 80%, 90%. They give you a bunch of percentages and then 85%. 85% is the answer. Okay, this is just one of those ones you have to know. All right. Intraoperative is done. Let's talk about post-op complications. All right, again, be vigilant. All right, your patient's complaining about something, don't blow it off. All right, pain is pain, but if they're complaining about pain that doesn't make a lot of sense, figure it out. The first one we got to know, talk about shock. Okay, shock can happen intraoperatively as well, but typically that's, you're already managing that. What the definition of shock is, the inability of the body to meet the metabolic demands of the cells, okay? Your symptoms of shock occur because you cannot meet that demand. And the most common reason the cells become dysfunctional is hypoperfusion. That hypoperfusion can occur for a lot of different reasons, but they're not perfusing well. There are much different kinds of shock. There's actually, this has been expanded into like 7 or 8 categories now, okay? Originally it was hypovolemic, cardiogenic, septic, neurogenic. There's a few others. The key in your boards, and really in practice, is hypovolemic and septic. Those are the two you really need to know about. If they're cardiogenic, I'm hoping you're having some help. If they're neurogenic, hopefully there's somebody who's managing somewhere above the head and involved in the care. And the key between hypovolemic and septic shock are these two things: cardiac output, SVR. All right, that's how you tell the difference. In hypovolemic shock, they're healthy. They're trying to keep perfusing themselves. They're doing their best to perfuse. And the way the body does that is by clamping down their peripheral vascular supply. They're clamping down the unessential organs, your arms, your legs, all that stuff, trying to preserve heart and brain perfusion, okay? At the same time, they have low cardiac output simply because they have a low stroke volume. They don't have enough fluid in their body, so their cardiac output tends to run low. Septic shock, the pathogenesis there, they have very low SVR because they have massive dilation of their capillary beds. Okay, so they have extremely low SVR, and the way they're trying to compensate is they're trying to pump out as much fluid as they can to fill those capillary beds. So until they start crumping, their cardiac output's high and their SVR is low. They will actually show you on the exam sometimes. They'll give you this exact chart. All right, they'll say, you have a patient with low, low, high, low. Okay, forget about CVP and O2 sat. Don't forget about that. This is where your answer is, those two right there. Okay? So let's talk about hemorrhagic shock first, or blood loss. The physiologic response to blood loss, your initial response, the body increases cardiac output. All right, it wants to keep perfusing. So it increases its pulse, you get tachycardic, you increase your contractility. all right? The peripheral resistance to the non-essential organs will start to clamp down too because they want to perfuse your essential organs. From the kidney, you activate your renin-angiotensin system, which will promote, also clamping down, will promote retention of fluid and vasoconstriction. And then from the neuroendocrine system, you'll get ADH release, also helps you hold on to fluid, hold on to salt, which helps you hold on to fluid. So the idea is to increase your intravascular volume. Yes? Generally about over 15%. That's actually the next slide. So this slide you really need to know because they also, I know I'm saying this almost every slide, so I'm sorry about that. But this one they will give you, and I see this a lot. They'll say you have a patient who has, their pulse pressure is this, their respiration is this, their urine output is this. What class shock are they? There's 4 classes of hemorrhagic shock. You generally, in answer to your question, if you've lost less than 15% of your blood volume, you don't have a whole lot of change in anything, okay? Class 2, that's class 1. Class 2 hemorrhage, you've lost anywhere from 15 to 30% of your blood volume. That's when your pulse starts to go up, your pulse pressure starts to drop, your urine output starts to teeter a little bit, okay? Class 3 shock, you've lost 30 to 40% of your blood volume. If you haven't started resuscitating them yet, their pulse gets up to 120, your urine output really starts to drop. And then class 4 shock, you've lost over 40% of your blood volume. Here, you're just crumping like crazy. The key here, they'll give you a patient who has no capillary refill and no urine output. All right? If they have no urine output, no capillary refill, they're class 4 shock. Okay? But they'll give you all of these things in the question. They may even put it in a table form. They may say, here's what they have. Table, bang, like this. Generally, they're not going to give you a class 1, generally. I mean, they're normal, so they're not going to give you that. Generally, they're not going to make you differentiate between a class 2 and class 3. They're really going to give you a class 4. Okay, they're going to give you a really sick patient, or they're going to give you a class 3. They're going to give you one of those two as a general rule. I would say no 2, 3, and 4. Just know them. And you can tell that really the key to knowing them is the pulse rate, the urine output, and the capillary refill. That's what tells you that those are the key factors. All right? How do you manage it? Most of you guys know this. Fluid resuscitation first. Isotonic fluid is the key. If their pressure improves, you just support them. All right? If they remain hypotensive, then you start transfusing them. Remember to transfuse all products if you need to, not just red cells. Okay? And that depends on volume. Initially, generally, you start with just a few packs of red cells. Once you're up to 4 packs or so of red cells, your 3rd or 4th pack, now you got to start thinking about doing blood products. Okay? There's no right way, right amount, right quantity. You kind of have to just follow it and chase it. Generally, they're going to not ask you how many of this, how many of that would you give. That's not what they're going to do. Okay? They're going to say patient is on her 4th or 5th unit of blood. What else do you want to get? All of these things are appropriate in your answer. So they'll say all the following except. And they'll say this, this, this. And the except will be, I don't know what it'll be, something else. Guidelines for transfusion. Generally, a healthy patient, generally you don't transfuse them unless, if their hemoglobin is less than 8 and they're symptomatic. Okay? If they're less than 8 and they're not symptomatic, you do not have to transfuse them if they're a healthy patient. All right? Symptoms, oliguria, hypotension, tachycardia, mental status changes, obviously your symptoms. All right? But as a general rule of thumb, they can tolerate lower levels. You know, we've seen people in the 5s and 6s who just live with it. That's okay. If in patients with risk factors, if they give you a patient who has active heart or pulmonary disease, they require a high level of oxygen carrying capacity. These people you transfuse at a higher level. They may not be symptomatic, but when they become symptomatic, they get sick. So you don't want them to get symptomatic. Okay? DIC. DIC is a process, not a disease in and of itself. So what you have 2 things going on with DIC. You have intravascular clot, all right, fibrin deposition. At the same time, you have a consumptive coagulopathy, which is causing hemorrhage. So you have bleeding and clotting at the same time. DIC is not a separate entity by itself. DIC usually is in a setting of something, okay, some other process. The most common ones we see are shock, hemorrhage. You know, that's what we're talking about right now, but you can see it with infection, obstetrical complications, transfusion reactions, other end organ pathology. But DIC is not an entity in and of itself. It is an end result of some other disease process. Pathophysiology, you have some kind of underlying disorder, one of those things I talked about. It results in systemic activation of coagulation, which then becomes dysfunctional. You have consumptive coagulopathy, you start chewing up your platelets and clotting factors, and eventually you get into bleeding at the same time that those platelets, clotting factors are being used to create microvascular thrombosis. All right, so you get end organ disease while you're bleeding. Okay, the end organ disease is because of clotting. DIC is really a clinical diagnosis. You know, you can use laboratory, you do use laboratory values as well, but really it's more of a clinical diagnosis than anything else. You have the clinical picture of bleeding. At the same time, you have a thrombocytopenia, that's that consumptive coagulopathy. You can see schistocytes because of hemolysis. D-dimers are up because of the clotting. FDPs, again, clotting. Fibrinogen is actually one of the things we used to follow a lot when I was a resident, but it's a really rapid acute phase protein. It responds very, very quickly, and it can recover very, very quickly, so not something I would hang my hat on necessarily. Really, the key on any kind of exam would be the platelets. That's what they really want to focus on in a clinical picture. High thrombocytopenia, clinical picture of bleeding, you want to think DIC. The way you treat DIC, you got to fix the underlying cause. Okay, if that underlying cause is still prevalent, it's going to keep happening until you fix it. At the same time, you support them as much as you can. You replace platelets and clotting factors only if the patient is having active bleeding that you can't stop. They're going to keep chewing up the platelets and clotting factors you give them. Okay, so if you don't need to give it to them, don't treat a number, treat the patient. You generally don't use cryo in DIC. This is a board question. All right, they will say, how do you want to manage it? They'll give you the choice of, red cells, this, that, cryoprecipitate, or they'll say FFP. Okay, you want to use FFP because you're missing factor V in cryo. Heparinizing DIC is very controversial. Generally, you don't do it unless you're really suspicious of end organ thromboembolic disease. So you really avoid heparinizing these people because they're at risk for bleeding anyway. All right, so now we talked about hemorrhagic shock and DIC. Let's talk about septic shock, the other kind of shock they're going to ask you about. The definition of septic shock, you have to have three things going on. You have to have an active infection. That's number one. Number two, you have to have the systemic inflammatory response syndrome, which I think that name's been changed 12 times, so it might have changed again. I don't keep track of it. And that is indicated by purely symptoms, or signs, temperature, high or low temperature, tachycardia, tachypnea, and white counts that are either high or low. Okay, these are things, these are not, you don't have to have all of them, but these are, you have to have these criteria. And the third, the shock part of it, is you have to have persistent hypotension. That's the shock part of it, end organ problem. Long, busy slide, but here's how septic shock works. First, you get bacterial toxins. This sometimes get asked. What causes shock? And they'll say gram-negative endotoxin, gram-positive endotoxin, gram-positive exotoxin, gram-positive endotoxin. They'll give you like a very complicated thing. Gram-negatives, endotoxin. Almost all of us know this, and we've encountered this at some point in time. I didn't know this until I looked into it, but if a gram-positive organism is causing shock, it's because of an exotoxin. All right? But most commonly, they'll give you, like, they'll try to trip you up with this. Just remember gram-positive, gram-negative endo, gram-positive exo. What happens when you get the endotoxin? It attacks the host immune cells, causes the results of cytokines, okay, from the immune system. The cytokines result in vasodilation. I don't think you have to memorize all the cytokines. Don't worry about that. I just put it in there for your education. Nitric oxide is the kind of the big one we worry about, or that gets activated. The vasodilation results in hypoperfusion and capillary leak. The vessels become leaky, they become dilated. Your big splanchnic beds just massively dilate, okay? You get then intravascular depletion because your blood is now filling these beds all over your body that don't usually need this much fluid. You get a localized hypotension in the organs, so because you're not perfusing your kidney, your liver, your lungs well, they start to become hypoperfused. They become hypoxic. The hypoxia results in mitochondrial dysfunction, and that kills your cells. You get end organ dysfunction. And eventually you get systemic collapse. So this is the process, okay? The reason I bring it up is most of the time when you're thinking septic shock, you're already somewhere over here by the time you realize where you're there. So if you see a patient who's got hypotension, but happens to have, you know, their creatinine is starting to bump, their LFTs are going up, they're a little hypoxic. These are all signs of end organ disease. Young patients will hide it sometimes. You can get away with young patients will tolerate a great deal of sickness. So just if you start to see that stuff, keep in the back of your mind septic shock. All right, diagnostic evaluation. Well, you ordered labs out the wazoo on these people because you're trying to figure out the problem. But, you know, CBC, electrolytes, you're looking for, you know, this really more looks at kidney function. Coagulation studies actually really looking mainly at DIC, which can result, as well as liver function. Lactate is a marker of hypoxia. Glucose. And then you always culture the heck out of them, try to find the source if you don't know what the source is. Chest x-rays, generally you want to get that in all patients, even if you don't suspect pulmonary disease, because these people will get pulmonary edema pretty quickly. So you want to have kind of monitoring of their lungs. Treatment, aggressive hydration. You cannot give a septic shock patient enough fluid. You can put 12 liters in these people and their pressure doesn't bump at all because their splanchnic beds are just huge. Hydrate the hell out of them. The first treatment for septic shock is hydration. All right? That is your board answer right there. Okay? Hydration. Goal is to maintain your CVP 8 to 12 millimeters. They don't ask you that. Pressors really only after you hydrate them. If you give a patient a pressor after inadequate hydration, you basically will cut off the blood supply to their organs and their splanchnic beds, and you're gonna hurt them. So you cannot hydrate these people enough. You just can't do it. And then you do whatever you need to do to maximize their oxygen carrying ability. So you want to keep their hemoglobin up above 10, okay, so they have better oxygen carrying capacity. Go ahead and intubate them, even if they don't necessarily have respiratory compromise. Sometimes you just go ahead and intubate them anyway to maximize oxygenation. And then obviously you want to treat the infection aggressively. Any questions about shock?
We can just automatically think that they already have central monitoring.
So the question is assume that they have central monitoring. I wouldn't assume that necessarily. You're talking about in a board question.
Right.
Yeah, in a board question, they may give you all kinds of stuff. You know, they'll give you, got a central line, CVP is this, you know, all the values you see with the Swan GANs. They'll give you all that crap in there. And then they'll say, how would you want to manage this patient? If the diagnosis is septic shock, you really, a lot of the times these board questions, and I'm sure they have this as part of your course today, this week, but they give you all that information to kind of, you know, hoodwink you, all right? And when the answer's staring you right in the face. So if it's septic shock, ignore all those numbers. You know, they're not going to ask you to make a diagnosis in a septic shock case based on CVP, et cetera. If it's septic shock, hydrate them. And that's what they add. They really want to know that you know what to do. Not necessarily that you make the diagnosis. They're not going to say, what's the diagnosis? Usually they'll say, what do you do? And what you do is you hydrate the hell out of them. Oops. Venous thromboembolism. That's the next post-op complication. 50% of your venous thromboembolic events will occur in the first 24 hours. 75% in the first 72 hours, 85% in the first week. Okay? Prevention is the key to venous thromboembolism. All right? Virchow's triad, from step one of your boards all the way through your written OBGYN boards, this question gets asked. Okay? This is just know it. What else to tell you? Just know it. Hypercoagulable states. Hypercoagulable states? All right, anyway. These things make you bleed more. Antithrombin 3 is the most potent hypercoagulable state there is. Okay? If you have it, you're at the highest risk of all of these for clot formation. This also is a board question. Okay, what is they'll flat out ask. This isn't a vignette question. This is what is the biggest risk factor for thromboembolic events, and antithrombin 3. Now, I'll tell you, there are hematologists who have never seen this. It is that rare, but it's still the most potent. Okay? You guys know most of these from, you know, managing this. How do DVTs form? They almost always start in the calf. They usually catch on a valve. You form a little clot. The clot becomes bigger and gets bigger. 80% of clots, however, resolve spontaneously. You'd be surprised at the number of patients who develop clots and they just go away. They're pretty common if you really go chasing it down. So most of the time, you don't get crazy about a bit unless they're symptomatic. Presentation of a DVT, unilateral edema is the most common sign. The rest of it is really not terribly, specific. You have leg pain 50% of the time. Homan's sign is only present 30% of the time. 50% of people who present with it will have no DVT. So just because they have it doesn't mean they have a DVT. And remember this one, 10% of people, their first presentation of their DVT will be their lung event. Okay, will be a PE. They become obviously more symptomatic the more proximal the clot. How do you diagnose it? Most people, the most common test done is Dopplers, ultrasound of the leg. All right. Less accurate for calf DVTs, but calf DVTs, again, most of them can spontaneously resolve. D-dimer is a rapid test. It's much more rapid. You can get that really quickly. So typically the ERs will use D-dimers because the patient's walking in the door. They want the answer right then. Generally our patients or post-op patients, we're going to get Dopplers on them because they're not, we don't need to know that fast. Additionally, D-dimers are elevated in surgical patients anyway, so it's less valuable in a surgical patient itself. You could do this impedance plethysmography, MRI. So this question gets asked a couple of ways. They may ask, what are tests can you order to diagnose a DVT? And they'll give you they'll give you any one of all of these and then like a CT, and the CT is wrong. Or they'll say, what is the best test? They don't usually ask that question. But the gold standard test for leg clot is Dopplers. How do you manage DVT? Anticoagulation. Intravenous heparin is what you start with. You can use low molecular weight heparin as well. No right answer there. You can go either way. They're not going to make you choose between the two because they're both right. Okay? You usually do that till you load up Coumadin. The nice thing about low molecular weight heparin, it's weight-based. If you're taking the oral boards, my advice is just know one of these. They're not going to ask you to give different ways to manage it. They'll say, how would you manage it? And you just have in your head the right way you would do it. Okay, pick one, pick a Lovenox or one of the other ones, and just know the dosing of it. You do not have to monitor patients on low molecular weight heparin. That's another thing you need to know. Heparin you do have to monitor. How long do you manage? How long do you anticoagulate them? Anyone for just a first DVT, 3 to 6 months. Symptomatic, just calf-only DVT, 3 months. Asymptomatic calf DVTs, you don't actually have to treat them. And most hematologists do not treat asymptomatic calf DVTs because a large proportion of them will resolve spontaneously. Okay? If they become symptomatic, that's different. So what you do if they're asymptomatic, you have a calf DVT, you just tell them to do their normal business, walk around, use the muscle, repeat the ultrasound in 14 days. If it's still there, then they treat. High-risk patients who get a clot, they're on anticoagulation forever. So. All right, filters, the use of filters, really it's failed anticoagulation. Filters kind of is a secondary backup method. People who propagate on anticoagulation, people who develop PEs on anticoagulation, if you have a contraindication to anticoagulation, these people get filters. And then there's Coumadin. All right, so PEs. PEs is the leading cause of preventable in-hospital mortality across the board. All specialties, all medical illnesses. This is the most common cause of in-hospital mortality. 300,000 deaths annually. Of all deaths from GYN surgery, 40% of them come from PE. Okay, very, very common. The incidence is not terribly high, but you have to be very conscious of it because 10% of people who develop a PE will die in the first hour. Symptoms, shortness of breath, chest pain, apprehension, sense of impending doom, that's my favorite one, and cough. These are the ones they'll show you. Patients with a PE will have all the following symptoms except, or in the vignette, they'll give you all these. And your patient's complaining of this, 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 and this. Immediately your head should go right to PE. They like to ask PE questions, DVT questions. They like to ask this. This is a dangerous condition. They want to make sure you guys know about it. All right, so anytime they start giving you a chest pain vignette, shortness of breath vignette, PE should be right at the top of your diagnosis. Okay, they may head fake you, but most of the time it's going to be PE. The signs you see are tachypnea, rails, tachycardia, but tachypnea is the one, just a rapid rate. The workup, the other one, I don't think I have this on here. EKG, what's the most common EKG finding in PE? Anyone know? normal or sinus tachycardia. Okay, that R1, S1, whatever the hell that is, that's not, it's sinus tachycardia or it's normal. All right. How do you manage PEs? Most of ours are going to be inpatients. Here's the outpatient workup in the ED. D-dimer is always the first. Inpatients, if you suspect a PE, go right to CAT scan. You know, most people with to do a proper spiral CT of the chest, you just need a second generation scanner. Almost every hospital has a second generation scanner now. If you have a third generation scanner, very, very accurate. If there's no PE, you don't have a PE. If you have a PE, you have a PE. If you have a first generation scanner, you can miss it. The cuts are not quite as good. If you have a PE, you treat it. If you don't have a PE, you move on and you keep working them up. Okay? So you have to know your scanner, know your capabilities in your hospital. If you have no PE but you really suspect it, you ultrasound their legs. If they have a DVT, you assume they have a PE. If they don't have a DVT, then you have to decide if you want to do a pulmonary angiogram. All right? This is the process. Yes? I don't know the difference myself. It's just a matter of how good the scanner is. It's the actual machine itself, the CT scanner itself. It's the size, it has to do with the size of the cuts and the resolution. The third generations, you can get millimeter cuts, high resolution. You can see really tiny clots. First generation, you really will only see the PE if it's a decent size or you happen to catch it in the right cut. But I can't give you more information than that. But the best thing, generally they're not going to say, in a written exam, not going to say CAT scan on a first generation scanner is blah, 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 blah. That's more for your knowledge and practice. Okay, they'll say, if they give you the vignette and you get the CT and the scanner is negative, I would just assume it's negative. Next step in management would be, I would assume it's a first generation scanner on the exam. I apologize. Assume it's a first generation scanner. I don't think they're going to go that way. I think they're not going to try to trick you in the diagnosis. They're going to tell you, they're going to give you the PE, and they're going to say, how do you manage it? Okay? Or what's your most likely diagnosis? But I don't think the CAT scan will actually come up in the exam. I'll be honest with you. I don't think they'll actually ask you about the CAT scan. How do you manage it? If they're hemodynamically unstable, you're going to thrombolyse them, TPA, streptokinase, whatever, unless it's contraindicated. All right? If it's contraindicated, then you have to talk about embolectomies. Okay? If it's not contraindicated, you thrombolyse them, maybe filter them. If they're stable, 9 times out of 10 they'll be stable. You have to decide if you can anticoagulate them. If they can't be anticoagulated, you do it. Heparin, low molecular weight heparin, whatever you want to give them. If they are not able to be anticoagulated, you filter them, possible embolectomy, go from there. But most of the time, they're not going to give you a patient who can't be anticoagulated. Febrile morbidity. Man, those are big books you guys have, by the way. I got to tell you. Enjoy. Hope you don't have to fly with those things. That would suck to fly with. All right. So, febrile morbidity. Temperature over 38 degrees for over 24, and it has to be later than 24 hours post-op. You can get an immediate in the first 24 hours fever. Usually, that cytokine release is not anything you worry about terribly much, unless they're sick when they're coming in. Febrile morbidity in the first 72 hours is almost always not an infection. Okay? Almost always. So if you get a fever in the first 72 hours after surgery, don't get crazy. Don't go order a million tests. 80% of these fevers are non-infectious. All right, there's a nice paper by Shackelford out of, I think, South Carolina. Everyone learns the 5 W's: wind, water, wine, walking, wonder, drug. These don't cause fevers. Okay? This does not show up on the exam. This is my own pet peeve. Atelectasis, there's nice papers out of the chest literature that shows atelectasis does not cause fever. These are people where they drop lungs during surgery and they don't get fevers. I've never seen a UTI cause a fever. I'm a urogynecologist. I see UTIs all the time. I've never seen a cystitis cause a fever. Now, pyelo is different, but I've never seen a cystitis cause a fever. If they have pyelo, they'll have flank pain. Wound, well, that'll cause a fever. Walking, that has to go with atelectasis. I don't know. And the wonder drug, yeah, that can cause a fever too. But walking's for DVT. DVT can cause fever. It can. So these 3 can cause fever. These first 2, no. Just don't. All right, so here's tricks in your vignette for what your diagnosis might be. If they give you a fever 1 to 3 days, they're going to want you to say atelectasis, even though I say it doesn't cause fever. That's what they're going to want you to say. If it's 3 to 7 days, this one they do like to ask, is they want you to say pneumonia. Pneumonia is one they do ask periodically on this exam. If you get a fever in 3 to 7 days, they'll give you some pulmonary symptoms, usually. Most of the time they should. There. Wound infections typically occur 5 to 10 days post-op, with the exception of this really, really bad one. So in the timing, you'll see that. DVTs, anywhere from 3+ days, you'll get the fever to start. UTI, as I said, I wouldn't hang my hat on that, but according to the exam, if you get 3+ days with dysuria, whatever, then you assume that's what it is. And any kind of GU injury, as I said, leaking urine from a ureteral injury, bladder injury, typically you don't see that for a few days before you start spiking temperatures, necessarily. Pneumonias, most patients who have postoperative pneumonia, it's a community-acquired pneumonia. They came in with it. Okay, they just happened to develop it, the ventilator exacerbated it. Most common organisms in community-acquired pneumonia are these three. They haven't changed much since I was a medical student. This one just changed names. Legionella, Mycoplasma, Chlamydia are the atypical. So these are the most common organisms. Streptococcus, pneumococcus, this is the most common one. All right, by far and away the most common one. So if they ask you what's the most common organism in this patient who's got shortness of breath and coughing and productive sputum and blah, 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 strep pneumococcus. Okay? Aspiration pneumonia, this is a bad one. There's two kinds of pneumonias. They get these are two kinds of patients. The first one is the chemical pneumonia. This is the one where the acid erodes the lining of their alveoli. And when they have that, they get sick real quick. Within 2 hours of aspiration, they get an ARDS type pattern, picture. You know, large AA gradient, fluid in the lungs, all kinds of stuff, respiratory distress, et cetera. These people get sick fast. Bacterial, these really are very indolent. They develop over time, and this has to do with the slow growth of anaerobic organisms in an aerobic area. So they typically eventually develop foul-smelling sputum as their classic sign. So a patient 2 weeks after surgery, fever, chest pain, productive cough, foul-smelling sputum. Foul-smelling sputum, aspiration. That's kind of that should be a trigger there for your vignette. How you treat community-acquired pneumonias? Monotherapy is appropriate. Ceftriaxone, 1 gram every 24 hours for those taking your oral boards. Just know that dose. You can add azithromycin if you suspect an atypical. That usually will be based on chest x-ray findings. You can't use this as monotherapy anymore because pneumococcus, 25% of it's going to be resistant. Aspiration pneumonias. Typically, you see a lower lobe infiltrate on x-ray. You'll get volume loss because of obstruction. You can get the pulmonary edema, and you can see an abscess, like an air fluid level in the lung itself. And you get all kinds. You can get any kind of bacteria, basically, gram-positive, gram-negative, or anaerobe, if you culture that out. Typically, aspiration pneumonias will affect the right greater than the left. Has to do with the straight shot of the right bronchus down, whereas the left takes a turn. How do you treat it? The chemical pneumonia is purely supportive. If they crump within 2-3 hours of surgery, it's not infectious. They don't get that sick that fast from infection. So you don't use antibiotics. They'll almost always give them antibiotics, but it's really supportive. That's the treatment, okay, for chemical pneumonia. So oxygenation, ventilation, manage their edema, diuretics, et cetera. Really don't need antibiotics, although most people would give it to them. For bacterial aspiration pneumonia, so these are the people who are a week or two later who developed the pneumonia. These people, clindamycin is your drug of choice. Okay? We're almost to the end of this section. Cuff abscess, I think we're almost to the end. Cuff abscess is usually the result of infected cuff hematoma. We see that all the time. How do you treat an abscess? Drain it. That's absolutely right. You drain it. Antibiotics, often because there's a surrounding cellulitis, you'll give them antibiotics anyway, but the treatment of a cuff abscess is to drain it. Put a Kelly clamp in the cuff, pop it open, put a needle in it, whatever you want to do to it. Just if there's a cuff abscess after hysterectomy, the cuff wants to open. All you got to do is kind of mess with it a little bit, and it'll just pop open because the body's trying to reject that inflammatory mess. So you just kind of poke at it, and it'll just pop and start draining. Cuff cellulitis. This is, they present with kind of a redness to the vaginal cuff, inflammation, fever, a little bit of pain, but you don't actually feel a mass, and a mass would be an abscess. Pain, fever, discharge, etc. Usually it's polymicrobial. Okay, no one organism you treat. 70% of the time it's anaerobes. Typically use some kind of broad spectrum antibiotic to treat this, and there's no right answer for antibiotics. They won't ask you what antibiotic to choose. Abdominal wall mass, they do periodically ask this. There's really two choices for an abdominal. Patient is post-op, presents with a mass in the abdominal wall. It's either going to be a hernia or a hematoma. I mean, that's really all it can be. Or dehiscence, which is kind of like a hernia. Dehiscence would be very soon after surgery. A hernia would be, a month or two down the road. So really, they're going to say patient with abdominal wall mass. They may give you a whole other paragraph of history that will help point to one or the other. Okay, timing is the clue there. Hematomas typically occur pretty soon after surgery. If the bulge shows up 2-3 months later, it's going to be a hernia. Pulmonary edema. This is a result of extravasation of fluid into the lung itself. Okay, it can be fluid from the interstitium into the alveoli. You can get fluid around the alveoli. You can have both. It's caused by increased intravascular pressure that pushes the fluid out of the vessels and into the interstitium, into the alveoli. That occurs obviously with heart failure, left ventricular dysfunction. If you have alveolar damage, so the alveoli are leaky, you can get fluid transitating into it. Any kind of lymphatic obstructions, basically anything that increases the pressure in the areas of your body where you keep fluid will push the fluid out into the surrounding tissue. Signs and symptoms. Again, these look a lot like the signs and symptoms with PE, right? And I told you, still, even though you got pulmonary edema on this, think PE. Okay, they really want you to know PE. That's what they want you to think about, all right? All right. How do you evaluate it? Obviously, you're trying to figure out why they have it, so you're looking for end-organ disease, CBC, electrolytes, et cetera, chest x-ray. Remember, chest x-rays can be delayed in its findings. If you have a patient who's not adequately hydrated, they could have pulmonary edema. You're just not seeing it. Remember, the white in the lungs is fluid, and if they're dehydrated, you won't see it. So sometimes you want to repeat the x-ray. If you really think they've got edema and the first chest x-ray was negative, hydrate them for a little while. You're going to be doing that to support them anyway. And then repeat it, and you'll often see the edema as a result. ABGs, the key to the ABG is a large gradient. Okay, they're not getting the oxygen supply into their arterial supply very well, so they have a large AA gradient. And then you do a cardiac evaluation. Number one thing you have to worry about with pulmonary edema in the absence of an external cause is, are they having some kind of heart failure?
Question.
Yes.
So we're supposed to always jump to PE rather than edema.
Yes.
This needs an X-ray. The other needs a CT. They're saying, what's the next? What imaging in order since they were on that line? Just go for the CT.
So the question was, I have to repeat the question, I'm sorry. So the question was, because we're cognizant of PE or this, one's an X-ray, one is a CT, which do you order? The PE is going to kill her quick, okay? PE is going to kill her quick. The edema will kill her slow, well, not necessarily terribly slowly, but a lot slower than the embolism can. So you always jump right to the CT. Okay, and really with a CT now, you almost don't need a chest X-ray because the CT will give you the answer anyway. But all right, how do you manage it? Supplement them. They're not getting their oxygen into their red cells, so you got to add oxygen to them. You treat the underlying cause. For cardiac, this is one thing they ask if they'll give you a patient if you suspect pulmonary edema in the vignette. Preload reduction. Afterload reduction, so you want to, get the heart pump going through the heart better perfusion, and then inotropic support. So these are all, they'll say, in this patient, you want to do all the following except, and they'll give you these three, and then they'll give you antibiotics, something like that, okay? So really just support. And this is just a general testing thing for you. If you get like 3 things that look pretty similar to each other in your multiple choice, and then one that's just completely off the wall, normally you want to do the one that's off the wall, okay? Unless it's one of those all of the following excepts, and then you do the other 3. And then you still do the ones off the wall, because I guess it's there. Anyway. All right, nerve injuries. Most common cause of nerve injuries occurs from retraction in the work we do. If you have your self-retaining retractor sitting on a nerve, it can become ischemic. Positioning, if you hyperflex the leg, you can compress the femoral nerve under the inguinal ligament. And then direct trauma, obviously, if you cut or injure a nerve, that's a problem. This is just showing you the lumbar plexus, which is the organs, the nerves we worry about. Really, from medial to lateral, the only one that's in the true pelvis is your obturator nerve, okay? Genitofemoral is a little bit more medial. This is the one that sits on the psoas muscle. Your femoral is lateral to the psoas, and then these go more lateral than that. So this is from medial to lateral in order, okay? We'll talk about the critical ones in a moment. Femoral neuropathy is the big one. This is the one you absolutely don't want to have if you can help it. The most common cause is compression, okay? The self-retaining retractor, if it's sitting on the lateral edge of your psoas, your femoral nerve is right under there, okay? And you can get a compression neuropathy. So you want to make sure that it's not sitting on the lateral edge of your psoas muscle. In vaginal cases, if you hyperflex the thigh, so the thigh, from the thigh to the trunk is past 90 degrees, you can compress it under the inguinal ligament. So you want to make sure you're not hyperflexed either. A lot of times, you put the drapes up, you realize you need more room, you crank the legs up a little bit more. Just be cognizant of where those legs are. What do you get with this? Well, you get motor and sensory loss to the anterior thigh. So you can't extend your leg. These people are dragging their legs when they walk. They can't raise or lift their leg. It's a very, very serious problem when these people have it. All right? The vignette won't be subtle. Patient can't walk, patient can't move their leg, patient can't go up the stairs in the vignette. How do you evaluate it? These symptoms occur almost immediately, right after surgery. So patient's complaining, this is not the patient, you say, well, give it a couple of days, let's see if it gets better. You act on it, okay? You need an EMG immediately. The EMG is not for treatment, it's for prediction of recovery, okay? The EMG is highly predictive of recovery. Immediately you put them into physical therapy, and this is critical, DVT prophylaxis, very, very important. These people will not move their leg, so they get clots, okay? And the recovery can take months sometimes, so it's very frustrating, but the physical therapy and the DVT prophylaxis is very, very important. Obturator neuropathy, classically these are injured during my cases, during reconstructive cases, or during oncology cases when you're doing your node dissections. Symptoms, inability to adduct the thigh, okay? I always joke with my residents, if you're going to injure the obturator, just injure the left, because you use your right to drive. You go from gas to brake, gas to brake, gas to brake. And if you injure your right, you can't go to the brake. You can only accelerate. That's a problem. So if you injure the left, just don't use a clutch. But I really don't want to injure any of them. But again, the same rules. You can't really EMG the obturator nerve, so you don't get EMGs in these people, but you get them into physical therapy real quickly. And they do recover unless there's a suspected transection, and then you have to get neurosurgery involved. Oops, I did it. I knew I was going to do it. All right. Give me a second. Nope, that's not what I want. Where's the slideshow?
You mean on the next one?
No, where's the slideshow? I just want to put the slideshow back up. Oh, there it is. All right, good. Okay, all the rest of the nerves you injure are sensory nerves, not that big of a deal. These are all just the locations you get the sensory loss. They really don't ask sensory questions, generally as a rule. The only one they might ask you is which one you injure, which one, you know how you do that, your C-section, and like a month later they come back and they got pains in the corner of their incision? You've almost always in those cases entrapped either your iliohypogastric or ilioinguinal or both, okay? Treatment is usually just injection therapy and time because the Vicryl or whatever you use will go away and everything is all right. So that might be the only question out of these they might ask you is what nerve is involved in a pain after a C-section kind of thing. Pudendal neuropathy, it's a complication. Really, it's hard to get it with a sacrospinous suspension, but it's doable. Typical symptoms you get with pudendal neuropathy, remember the pudendal nerve innervates the anus, the perineum, the clitoris, okay? So you can get fecal incontinence, you can get vulvar or clitoral paresthesias, and you can get pain, all right? So anyone who had a sacrospine, but again, in your vignette, again, these kind of things, they'll say patient had a sacrospinous suspension, patient has fecal incontinence. I mean, they're giving you multiple reasons to suspect it. And then the treatment for this, again, is just time, and even pelvic floor physical therapy is a way to manage it. Sling complications. These are starting to show up now because slings are becoming much more prevalent in a general OBGYN practice. In retropubic TVTs, slings, 6% bladder injury rate, pretty rare in transoperator slings, although it's happened. Voiding dysfunction. I'm not sure yet how I don't think they've quite figured out how they want to ask these questions, so I wouldn't spend a lot of time worrying about sling complications. Bladder injury is probably the main one that you want to worry about. The other one is voiding dysfunction. So if you make the sling too tight, you can get outlet obstruction or urgency frequency. Those are the complications they're going to want you to say. But I don't think you're going to see a lot of sling complication questions in the written boards. Just don't think it's going to happen. Rare injuries with the retropubic TVT, bowel, nerve, vascular, people have lost legs from TVTs. That's why the transoperator sling is the most common sling that we do for general gynecologists, I believe. I do both, but I think most people who are going to do slings in life probably should stick to transoperator if you're not don't do a lot of them. Ileus, I think it's the last group of slides I have on this complication talk. Nausea, vomiting, absence of flatus, diminishing bowel sounds after surgery. Typically, it's just delayed intestinal motility. Just everything's slowed down some. Okay, remember your order of organs to return. Your stomach comes back first. I'm sorry, your small bowel comes back first, your stomach comes back second, your large bowel comes back third. In general rule of what system comes back. The colon is the last to return. So in ileus, you have good small, you may have bowel sounds, you may not have bowel sounds from the small intestine, but you just have kind of a buildup in the colon. Part of the mechanism of that's thought to be sympathetic release, which slows the bowels down. Part of it may be an opioid problem when they get lots of narcotics during surgery. How do you treat ileus? Really just ambulation. You can even feed them if you want to. You don't have to feed them if they're nauseated. So really if they have an ileus and they're not nauseated, it's okay to keep feeding them because the actual act of eating can stimulate the bowels to start working. Some people have them chew gum. Chewing gum can stimulate the ileus to start working. You can use an NG tube, but that's not necessary. There was a nice Cochrane review looking at NG tube for ileus versus no NG tube. What an NG tube does is it just shortens your hospital stay by about a day and gets rid of the nausea. Okay, but obviously it's an NG tube. Having had one, it wasn't a lot of fun. And then medications really have minimal benefits. There's some new opioid antagonists that are coming out and different opioid pain medication that's coming out. But right now, just kind of tincture of time is really what you're talking about with ileus. One of the things they want you to know is can you distinguish between an ileus and a small bowel obstruction. Generally, if it's within the first few days of surgery, not bowel obstruction. It's an ileus. Okay, timing will be the key. All right, timing will be the key. Pain with an ileus is usually just discomfort. Really, not a lot of cramping because the bowels just haven't woken up yet. With bowel obstruction, the proximal bowel is trying to get past the obstruction, so you have a lot of cramping pain. All right, you have a lot of colic. Bowel sounds usually diminished with ileus. Everything's slowed down. With bowel obstructions, you can actually be hyperactive because the proximal bowel, again, is trying to squeeze. Radiography, you'll see symmetric distension of the small and large bowel, usually no air fluid levels. Okay, usually it's just everything's a little bit swollen. With obstruction, you'll see distension of the proximal bowel, air fluid levels. The air fluid levels are because of bacterial overgrowth and gas production from the bacteria. And you'll see them very commonly, and you'll see that step pattern. And they'll even describe that in the vignette. Patient has a stepped pattern of air fluid levels. Is a pretty classic clue. How do you treat a bowel obstruction? You decompress them first. Actually, a large proportion of these don't require surgery. You just put an NG tube in, and they'll eventually resolve the obstruction. You always want to monitor your fluid electrolytes, and then there is a reasonable argument to be made for giving them antibiotics because of the bacterial overgrowth. And only about 40% will actually require surgery. Last slide of this set is confusion. If they give you a vignette with a confused patient, it really could be anything. And I can't give you any pearls here other than look at your vignette and look at where they're taking you. Okay, look where they're taking you. The one that I would say they're probably going after, if confusion is the primary goal, is this one, drug and alcohol withdrawal. All right, alcohol withdrawal is kind of a big, 2010 kind of push right now. So that's what they're going after. Just keep that in mind. They might give you a patient, has the shakes, something like that. They'll kind of head you that way. But just keep in mind drug and alcohol withdrawal in the case of confusion.